This is a Chronicle podcast, bringing you ideas in the service of medicine.
From the Chronicle podcast system, this is Vender on Psoriasis, with Dr. Ron Vender. Based on the popular Vender on Psoriasis column in the Chronicle of Skin and Allergy, Dr. Vender provides brief synopses of recent significant clinical developments in psoriasis research, and provides his observations and comments to accompany each report. In each episode, Dr. Vender will answer questions and offer his expert observations and anecdotes on treating this chronic disease. If you have a question for Dr. Vender, or want to be in touch at any time, just send an email to vender@chronicle.org. That's VENDER@chronicle.org. And, if you attach a voice clip, we might even use your question on an upcoming episode. Support for this podcast comes from Sun Pharma Canada. Sun Pharma is a world leader in specialty therapeutics, and is now positioned to be an even larger contributor to the Canadian dermatology landscape. Learn more at www.sunpharma.com. And now, here's Jeremy Visser.
Thanks, Leona. Welcome back. I'm Jeremy Visser of the Chronicle of Skin and Allergy. You're listening to the Vender on Psoriasis podcast with Dr. Ron Vender. In our fifth episode, Dr. Vender will be talking about breastfeeding with psoriasis, the link between childhood psoriasis and tobacco exposure, and treating plaque psoriasis with tapinarof cream. Our first study looks at women with moderate to severe psoriasis and the reduction the study shows in breastfeeding, potentially due to worsening of disease. Welcome back, Dr. Vender. I haven't seen a lot of research on the impact of psoriasis on breastfeeding. What's your experience with these findings?
Hi, Jeremy. Thank you very much for asking me back for this fifth episode. So there's different ways to look at psoriasis and breastfeeding. So there is the obvious one: if a patient has psoriasis, is it safe to breastfeed? And the answer is yes, it's safe to breastfeed if a patient has a psoriasis, even if there is a psoriasis that comes in contact with the infant. This is safe to do. There's nothing contagious or infectious in these plaques. There are some people that have thought that there are some bacteria like Staph aureus in the plaques of psoriasis, but this is really not very common and has not been shown to be clinically significant. The other thing that people would look at is to say whether breastfeeding makes psoriasis worse. And actually, it makes it probably better. And we know that in patients that have psoriasis that are pregnant, during their pregnancy, their psoriasis tends to get improved. It usually doesn't worsen. And breastfeeding can mimic pregnancy. And therefore, during breastfeeding, the psoriasis should not be exacerbated. Now, there are some camps that think that after pregnancy or after birth, the psoriasis tends to return to its state, requiring then further therapy. Then that is possible as well. But in general, during breastfeeding, the psoriasis does not exacerbate. If it does exacerbate, then the use of topical therapies that may have been avoided during pregnancy can be started again. Some systemic therapies should not be used in breastfeeding, the traditional systemic therapies, as it can affect the infant. And so what is generally accepted is if the patient requires a biologic or more advanced type of therapy, such as a biologic, the use of certolizumab, Pegol, which is a pegylated monoclonal antibody, can be very beneficial in treating these pregnant or breastfeeding psoriasis patients. It does not cross the placental barrier during pregnancy. There's little or no crossing, and little or no crossing in breast milk. The crib study that was done with certolizumab showed little or no monoclonal antibody crossing into the breast milk, and therefore has been accepted to be safe for breastfeeding infants of moms that have psoriasis and can be treated with certolizumab.
Our next study looks at childhood tobacco exposure and the potential link to childhood psoriasis. What's your take on this study, Dr. Vender?
The childhood tobacco, it's very controversial. I think that I almost rather go around this question. And we know that psoriasis can be genetic. If there are two parents that have psoriasis, there's a higher risk. I think that's much more important. Smoking in pregnancy is very uncommon nowadays. Maybe in other countries where smoking is common, but generally it is widely internationally known that smoking during pregnancy is not safe for the children. Could that be linked to childhood psoriasis? There are numerous environmental triggers. We know that smoking is associated with palmoplantar psoriasis in adults, and discontinuing smoking can improve those particular special sites of psoriasis involvement. There are no studies that I'm aware of that looks at smoking causing generalized plaque psoriasis. We know that smoking is associated with comorbidities associated with psoriasis. So I think that in general, for the health and safety of the infants, generally smoking is not occurring during pregnancy. Does that increase the risk of psoriasis? I would say that it would be considered a toxin. We know that toxins or these type of chemicals are not truly associated with psoriasis. So although this study did show a slight increase, likely it is a very, very low risk. And I think that in general, the health of the children or the infant is more important for other concerns of the mother smoking during pregnancy.
Our last study looks at tapinarof 1% cream in treatment of plaque psoriasis. Dr. Vender, what did you think about the findings of this study?
Well, I was quite impressed. I think that since the advent of topical steroids as a mainstay of treatment for plaque psoriasis around the world due to the cost, that topical psoriasis is still required for some anti-inflammatory, antipyretic type of activities that are needed to treat the patients that have psoriasis. Now, since topical steroids have been released, then there are patients that are steroid phobic or could be allergic to topical steroids. And the concern, because psoriasis is a chronic, long-term immune-mediated disease, that long-term use of topical steroids can cause thinning of skin, telangiectasia, possibly poor skin healing. And so there's always been a lookout in research for non-steroidal topical treatments for psoriasis that are safe and effective to use. In the past, off-label usage such as calcineurin inhibitors such as pimecrolimus and tacrolimus have been used in clinical studies for psoriasis, although they're not indicated for this, to show some benefit, but never really was a good benefit. Other topical treatments that are used off labels could be such as crisaborole, which is normally used for atopic dermatitis, has been attempted with very little success in the psoriasis patient. This tapinarof cream has shown to be in clinical studies to be very effective. Now, topical therapy never reaches the efficacy levels of biologics, although the topical treatment of tapinarof can be very effective. The other benefit is that it's non-steroidal, does not cause thinning of the skin, causes very little irritation, and has shown to be a benefit for treatment plaque psoriasis. So there's a benefit to this chronic use of topical treatment that can be used alone in, let's say, mild to moderate cases and even severe cases, but may also be used in conjunction with some systemic therapy or possibly with ultraviolet light, with cautions, and even in addition to biologic therapy. One would hope that this topical non-steroidal treatment that hopefully will be released soon in Canada may show benefit that may avoid systemic therapy or biological therapy. Also, the simplicity of its use, that it can be used head to toe and without particular cautions of sensitive areas like the genitals or the face, like some topical steroids that have to be titrated lower to benefit these particular areas with respect to safety. This tapinarof cream can be beneficial in those areas as well and very well tolerated. I think that the real world evidence, when it becomes released, will show us whether this non-steroidal topical therapy can be a benefit alone with patients.
Now for our listener questions. The first question comes from British Columbia. One of the studies today looked at childhood tobacco exposure and its link to childhood psoriasis. They did this irrespective of other environmental factors like intrauterine tobacco exposure. Are there any other potential environmental factors that could be linked to childhood psoriasis?
Well, thank you very much for the question. And I'm not aware of many studies that have a large enough number of patients that looked at environmental factors that are associated with childhood psoriasis. The environmental factors are certainly more important and are linked to atopic dermatitis. So depending on certain areas of the world where it is more common to have atopic dermatitis, such as in colder climates. The environmental factors that can be linked to childhood psoriasis are likely due to external factors such as potentially poor health or comorbidities associated with the parents as a possibility. So, for example, if both parents have psoriasis and multiple comorbidities that are difficult to treat, it is possible that there's an increased risk of childhood psoriasis, but that's more genetic than environmental factors. And so I'm not aware of any particular environmental factors that are directly linked to childhood psoriasis. And I would rely more on genetic factors that would be linked to childhood psoriasis. It's hard to delineate because the environment has so many external concerns with pollution and types of water, hard water, soft water, etc., that it'd be hard to prove that.
The next question comes from a listener in the Greater Toronto area. What considerations are there for prescribing psoriasis treatments to women around childbirth?
Well, thank you very, very much for the question. And so the considerations for prescribing psoriasis treatments around childbirth is different than the recommendation of psoriasis treatments throughout the whole of pregnancy. As mentioned earlier in the podcast, we discussed the fact that generally during pregnancy, there is no exacerbation of psoriasis, and those mothers that are at risk for exacerbation of the psoriasis can safely use mid-potency topical steroids. If their psoriasis is more severe or family planning has been discussed with the prescribing healthcare provider, most likely a dermatologist, then the use of certolizumab, a pegylated monoclonal antibody, and the TNF class can be very beneficial, as different studies have shown little or no placental transfer and safety for the infant throughout all of pregnancy and also through breastfeeding. Generally, the other biologics are stopped in the third trimester. And due to the half-life, I usually tell my patients to stop their biologic if they wish, although I have had patients continue other biologics besides certolizumab throughout pregnancy and have normal children. I generally recommend that it stops in the third trimester, or it's easier to calculate halfway through their pregnancy. And so with a 40-week pregnancy at 20 weeks, instead of waiting till the third trimester, just halfway through their pregnancy, they discontinue the biologic and then can restart it immediately after the birth of their infant.
Our last question comes from the GTA as well. What is your general approach to topical treatment of mild to moderate psoriasis?
So thank you very much for the question. That's certainly a very, very broad question. I believe that it always depends on the insurance, unfortunately, that a patient may have. Mild to moderate psoriasis can be easily treated with the same treatments as moderate to severe psoriasis, although indications for certain drugs may be different. So generally, in a stepwise approach, we would use topical steroids or topical combination products, and hopefully new topical non-steroidal therapies such as tapinarof or roflumilast for psoriasis patients. But at the present time, for mild to moderate psoriasis, mid-strength topical steroids can be beneficial, lower strength for the face and folds areas. Ultraviolet light can also be used where it's available. And mild to moderate psoriasis could also be treated with general systemics such as acitretin, rarely cyclosporin in most provinces, and methotrexate as well can be used in mild to moderate. It really depends on what's considered mild to moderate. Is facial psoriasis considered mild to moderate because there's little body surface area and not a lot of redness, thickness, and scale? Is palmoplantar, again, because of have 4% body surface area with, it could be severe redness, thickness, and scale, but the BSA is low. So it depends on how mild to moderate is defined. Is scalp psoriasis, is that considered mild to moderate? Very difficult to treat, or genital psoriasis as well. So if it's moderate psoriasis, you can still use biologics if they fulfill the specific criteria. Really, anything that you would use for moderate to severe could be used for mild to moderate. You know, we often don't remember that when we treat a moderate to severe patient and they become mild to moderate, we continue with that biologic if that's what we use for moderate to severe. So in a sense, we're treating a mild to moderate patient at this time point with a biologic that is generally indicated for moderate to severe patients. And so maybe if prices come down, or if insurance becomes to realize that treating these patients with mild to moderate psoriasis can give better long-term control and may prevent joint abnormalities in those that have psoriatic arthritis, that it is possible that we'll be able to use these biologics for mild to moderate severe. And one must not forget oral apremilast as well, that it has been used with great success for moderate to psoriasis.
Thank you, Dr. Vender. Listeners, if you have comments or questions for Dr. Vender, send them over. Send an email to health@chronicle.org. Add a voice clip attachment to your questions, and you might appear in a future episode of this podcast. If you enjoyed this podcast, please share it with your friends. You can subscribe at Apple iTunes, Google Podcasts, Stitcher, or wherever you get your podcasts. This podcast is produced in cooperation with Sun Pharma Canada. I'm Jeremy Visser of Chronicle Companies. Your host has been Dr. Ron Vender, founder and director of Vender Innovations in Psoriasis, a center of excellence for psoriasis offering a comprehensive management solution for individuals with psoriasis. We'll talk again next week.